Hello, everyone. My name is Dr. Claudia Hawkins, and I'm the director of the Center for Communicable and Emerging Infectious Diseases at the Robert J. Havey, MD Institute for Global Health and professor of medicine and infectious diseases at Northwestern's Feinberg School of Medicine. Thanks so much for taking the time to join us this afternoon for the latest installment of the Havey Institute's Global Health IGH webinar series, Roadmap to Botswana, Ending the HIV/AIDS Epidemic, which is co-sponsored by the Third Coast CFAR. Please take a moment to follow us on Facebook as well as Twitter and Instagram at FSM Global Health. In addition, we welcome you to be an Institute member to receive special access to resources and services that support research infrastructure. So today, we're thrilled to host Dr. Joseph Makhema for this seminar event. I have had the pleasure of knowing Dr. Makhema since the early days of the HIV care and treatment rollout in sub-Saharan Africa, and more recently, in a more personal capacity through our collaboration on the HBNU Fogarty Global Health Program. Dr. Makhema is the CEO of the Botswana Harvard Health Partnership, following formerly the Botswana Harvard AIDS Institute Partnership, so BHP. He obtained his medical degree at the University of Nairobi and is a fellow of the Royal College of Physicians in the UK. He's an internal medicine physician by training. He provides strategic leadership, coordinates and oversees research and training activities conducted at the BHP. He advises on the selections of protocols for the Botswana clinical research sites and participates in quality management systems, including monitoring and evaluation studies conducted at the BHP. He also interacts regularly with relevant stakeholders and participants in various Ministry of Health and National Technical Working Committees. Dr. Makhema is co-PI of the BHP Clinical Trials Unit, which we'll hear a lot more about today. These are affiliated with the ACTG Impact, HBTN, COVI-PN, and is site PI for HBTN and COVI-PM. He oversees a large team of clinical staff implementing multiple trials in parallel under many under investigational new drug applications at 2 clinical research sites in Botswana. The BHP has become a center of clinical trials excellence with successful performance in external trial monitoring, including the recent successful EMA inspection for the HBTN 084 study, which demonstrated the superiority of injectable cabotegravir to oral PrEP for prevention of HIV in cisgender women. There will be time for questions following the presentation, so we welcome you to submit your Q&A questions through the Q&A feature at the bottom right-hand corner of your screen throughout the presentation. Now, Dr. Makhema, I will turn it over to you and welcome again to you.
Thank you very much, Claudia. I think it's a singular honor for me to have been invited for this particular seminar. And I trust that we'll have a good few minutes just talking through what's happening in Botswana as we've put in place systems to try and cap the HIV epidemic. So thank you very much for inviting me. I have started screen sharing. I hope it is visible. This is where we are located. That's our iconic building and on the grounds of Princess Marina Hospital. Just briefly, we were established in 1996, and we believe that we're now a center of clinical research excellence and are one of the major network clinical trials units doing all sorts of interventional trials and observational studies. And results from some of our trials have helped to guide guidelines and policies throughout the globe. We still believe we can grow to be the public health institute that we all aspire for. All this has really come about as we as a country, based on some of these schematics, were really at the verge of extinction. Botswana, we know that was probably at the time that our former president went to the UN General Assembly saying we're threatened by extinction. It was a chilling thing for a president to acknowledge. And we have then, with the collaborations that subsequently ensued, set up all sorts of systems to ensure that we begin curbing and fighting the epidemic. Every epidemic requires certain components. And I think as one refers to President Mokhai, we really have to have the leadership, you have to have the community engagement, you have to have the infrastructure, the collaborations that were started by Professor Essex and others, and the subsequent citizenship scientifically and the appropriate training to ensure you've got competent persons who would be dealing with such epidemic for you to develop the systems that are required and the protocols to curtail the actual epidemic. And so we have over the years have lessons that we have learned as we have tried to control our epidemic. And there's a milestone chart here of when we started in 1996, starting off with a staff of 7, and having the first study in 1997, which was really an HIV molecular study which determined what kind of subtype of HIV was circulating in country. Moving on to other milestones, the training that was needed after we set up to ensure that people fully appreciated what we were dealing with. And the AIDS training program is one of our highlights. And it's an acronym that stands for Knowledge, Innovation, and Training Shall Overcome AIDS. I think it couldn't have been more apt at the time in 2000 when that program was set up, because it was set up to train all healthcare workers, laboratory, physicians, pharmacists, even the non-clinicians on various aspects of HIV/AIDS. And we subsequently had that iconic building, which was launched and opened formally by President Mokhai in 2001. And at the time, it was the first such dedicated laboratory for HIV research and capacity building within sub-Saharan Africa. And so it's from that lab that a lot of subsequent work has continued. And we subsequently, with various assistance from different programs, including Bristol-Myers Squibb, strengthens the infrastructure within the laboratory, resulting in building the extra infrastructural capacity. And one has gone through the different surveys at the time, you know, from 2001, systemically throughout the country, getting to know where we are in terms of the epidemic. The laboratory got accredited subsequently by the Southern African National Accreditation Society, and now we are an fully ISO 15189 accredited laboratory, continued building capacity, including now having multiple pathogen genomic tech capacity. And so those capacities were actually needed for us to move forward with our collaborations. One of the first studies that we focused on clinically were on PMTCT, prevention of vertical transmission, where initially we had multiple studies spanning Mashi, Mabana, which subsequently saw, as they were being implemented with the different recommendations that came out from those studies, the MTCT rates come down from nearly 40% at the beginning of 2002 when we set up some of those trials. And now we are at 1.1% or below, having had 98% reduction in mother-to-child transmission, which has resulted in the country receiving silver award from the World Health Organization for near elimination of mother-to-child transmission. And building on some of the early studies that we did, we now are at, in terms of mother-to-child transmission and studies, are looking at complete elimination of child HIV, or at least vertical transmission, having started a project on early antiretroviral therapy, starting treatments as early as the first week, which have demonstrated reduction in viral reservoir, and therefore one hopes that based on some of the MTCT cure research studies that had gone on, that is the way to go. And we are now establishing early infant diagnostic algorithms and point of care testing to try and curb this, the few transmissions that are occurring within our infant population. But insofar as the epidemic is concerned in Botswana, it still remains a generalized one. And whilst it is generalized, there are certain groupings that bear a bigger proportion than others. For example, girls and young women aged 15 to 24, whilst they form only 9% of our population, there's 24% incident infections within that particular cohort. And therefore, it is important that we continue to track and know our epidemic. And one of the biggest trials that we've ever done really mapped out how we could go on as a country in fighting the HIV epidemic. And it was called the Botswana Combination Prevention Project, or the YATSE trial, which involved an average of over 180,000 in terms of population, with communities of about 6,000, wherein we had 30 communities, 15 of which were randomized to standard of care, and 15 of which were randomized to rapid interventions in terms of home-based HIV testing, linkage to care by healthcare workers who went throughout the communities administering the testing, linking to care, and assisted by a lot of community healthcare workers. A really quite a mammoth project, but which demonstrated the need for you and how you have to go about in knowing your epidemic. The primary endpoint had been cumulative incidence over a 30-month period, where HIV incidence was determined in a prospective HIV incidence cohort of HIV negative residents, 20% households of all those communities, 15 of which were in the standard of care communities and 15 in the intervention communities. And this was going on in parallel with some of the other big community intervention projects, the POPAT project, or HP 10071, and there was the project in Uganda. And insofar as our project was concerned, we actually achieved amongst, because we started at relatively high at the time that the project started in 2013, there was already quite high knowledge of HIV. And if we start looking at some of the results, persons who knew their HIV status, 84%, and by the time we completed the project, about 5 years later, 93% of the communities where we were working knew their HIV status. Those who had been on antiretroviral therapy, 85%. And by the time we finished, they'd gone up after the intervention to 97%. Virological suppression didn't change that much because people who had been on antiretroviral therapy based on what had been ongoing in the country did continue to virally suppress. But the most important, I think, figure is that we were able to increase the populations of those persons who, in effect, had knew their HIV status, pushing them up to an undetectable level overall of 88%. So we were able, with this particular intervention, able to reduce the overall population HIV incidence by 31%. I think this was understated because as we went on along, there were opportunities for us to do phylogenetics to be able to find out in terms of a mixing within the population, the dilution factor of the intervention from the control to the intervention communities, and those data one will show later. But a key finding that impacted us controlling or beginning to take full control of the epidemic was that at the beginning of the epidemic, it began to focus where you needed to have your interventions targeting. The men, we got to find out that 37% of men knew their status at the beginning of the study, and therefore interventions had to be targeted and directed at them. And at the end of the study, we pushed this up to the 70%, and it's still not good enough. The youth were also another population who, in effect, had not been very keen at undergoing testing, but at the end of the study, we had them going up to 77% as well of those who knew. So there's still some gaps even amongst those populations. It focused the incidence amongst the women and adolescents where most incident infections were occurring compared to the higher, the older populations who had some of the lowest incidence. And therefore you could begin to target interventions based on some of the data that was generated from the BCPP. We took opportunity to do genotyping basically for most of the collected blood samples within the communities to determine phylogenetics and the clustering of infections within these particular communities. Now, we were able to have over 6,000 full-length HIV genome sequences from this particular study, trying to map out this phylogenetics and the various clusters for infection. And from our particular environment, the clusters where infections seem to occur as small as compared to some of the clusters that are seen in the Western countries, which are larger, and therefore you could easily throw a lot of resources at larger clusters to curtail the epidemic, versus where you've got multiple very, very small clusters generalized, if you would, and within the communities. And this demonstrated that for us, there's quite a high amount of sexual mixing between the communities, which is why one believed that even with the interventions that we did in those communities where the specific interventions were targeting those communities, the sexual mixing diluted the ultimate results that we subsequently had. The other aspect of what we did was to look at rates of drug-resistant mutations that were circulating, and we were happy to find that, and that I suppose one would have expected with the high rates of suppression of people who were on antivirals, that we had drug-resistant mutations that were below 6% for different groupings of antiretrovirals. And for a country that was the first to have started antiretroviral therapy within its nation, and in 2002, we think this actually was quite good. And so in terms of the BCPP overall, it helped us appreciate where the gaps are. And that we then as a country needed to begin focusing on those particular gaps. Obviously, with the UNAIDS targets of 95, 95, 95, and people now saying we focused on the 5, 5, 5, it is important that each and every country gets to know its epidemic. So we have seen over the years this HIV prevalence declining, but albeit because you've got as many people as we have proportionately on antiretrovirals, those who are infected, they are living longer, and therefore the prevalence is not going to decrease as much as one would want it to. And certainly the incidence has gone down from 1.07 in 2010, and the latest Botswana AIDS Impact Survey showed that this had decreased down to 0.29%. I've already talked to the issues around targeting adolescents and young women, and campaigns such as the DREAMS, which are PEPFAR funded, which target these adolescents and young women, are now being rolled out at different levels to try and address that issue. And we have to also focus initiatives on men. The key populations are another cohort which were picked up, where they have 62% prevalence amongst female sex workers, and then the other population which in effect we needed to target was the non-citizens. The data for the non-citizens showed that the non-citizens were actually not getting antiretroviral therapy or getting into care as early as they should have, and therefore they were as low as 20% who knew their status, and 37% of those who were on antiretroviral therapy. And that eventually convinced the government to include non-citizens in the entire program for antiretroviral therapy in the country. I think I will pause there and see whether there may be any clarification questions. Otherwise, that really was my intention, to just give you a synopsis of where we are in terms of the epidemic, what we needed to do to get to where we are in terms of attainment of the current 95 targets as per the Botswana AIDS Impact Survey in 2022, whilst we know that there's still some work targeting the 555 that are missing and need for us to focus our energies on. I thought it would be good for us to also, because we know that for us to be able to undertake and keep up the work, we need to be raising next generation scientists, and being part of the HBNU, I thought it would be good for us to maybe show you what our capacity building initiatives look like. Training capacity building is one of our core missions, and we are training dozens of, quite a few PhDs academically and master students in different laboratory and clinical sciences, where we undertake north-south, south-south bi-directional training. And as we did say with the Kitso training program, have trained quite a number of healthcare workers. And part of our training north-south includes some residency trainings from some of the Boston affiliated hospitals, and they do send some of their residents here for rotations to appreciate the global health. And these are some of the trainees that we have had over the years. Fogarty, the Motswedi Anderson on the top left there, got a PhD in hepatology, and she is setting up now capacity for us to expand on our hepatitis program at the BHP. Lerato Mahosi is at the University of Botswana. Professor Mosepele was as a research associate with us, and was the deputy coordinator in charge of COVID-19 in the country. And some of you may have heard of Professor Moyo, who was instrumental in Omicron discovery. And we are getting a few of these young scientists also getting awards. Recently had Guy Losiatla be one of 10 APTI fellows at the NIH, who's studying HIV genomics. And it's really an effort that we all are invested in ensuring that it happens. And we've got different programs for capacity building, certainly the Fogarty D43, the Harvard Global Health Institute, Global Health project where students from Harvard come over to the BHP for 10 to 12 weeks, working within the lab. The Sante, TESA, and those are different programs that are funded for capacity building. And the research areas for the fellows is really varied, from pathogen genomics, HIV drug resistance evolution, viral hepatitis, molecular epidemiology, HIV cure, like Catherine Gufetile is involved in HIV cure research, mycobacterium, TB is one of the killer diseases in our environment, and therefore we want to have adequate capacity there. And the SARS-CoV-2 dynamics, SARS-CoV was an eye-opener needed for us to pivot really quite quickly from HIV in addressing the SARS-CoV infection as COVID-19 hit us. Some of the HIV cure research questions undertaken by Catherine in picture there, who is also Boston trained. I think she spent quite a bit of time at in the lab at Boston, and she's interested in HIV cure research in adolescents and early treated infants, and looking at the reservoir in particular, how low it can become from children who are and adolescents who are treated early, and other different strategies for HIV cure. I think I still have time just to briefly give you what we have been doing in terms of COVID. Obviously, when COVID hit us, we pivoted, as I said, very quickly to putting in place the infrastructure to do the research, undertook studies on immune responses to COVID, and its evolution, obviously, within Botswana, and the SARS-CoV-2 evolution surveillance over time in Botswana, and the systems that were put in place for surveillance were the ones which ultimately led to the Omicron discovery by Professor Moyo along almost same time as Tullio de Oliveira in South Africa. So we are in the process now of going into genomics, looking at different pathogens within as part of our surveillance system, and whether it's in wastewater, HPV drug resistance, or whatever. But I mean, at the end of the day, we are expanding our portfolio, and all that is actually has been made possible by the infrastructure and the investments that are made for the HIV epidemic. Really, in conclusion, from the work that we have been doing, including with the COVID, some of the lessons learned are that you really do need to have your infrastructural capacity, and you need to ensure that you are constantly moving real time to sample in terms of disease surveillance, and to detect any resurgence of any new pathogens, or in the case of Omicron, new variants and lineages. And all that would not have been possible if at all we didn't have the different infrastructure to be able to undertake that work. And our platforms, and a lot of the platforms that were developed through COVID, rather through HIV, are now being used for other new emergent diseases. In a nutshell, so that we may have adequate time, I thought it would be great for us to have long conversations and interactions on the Botswana story in the different phases, for any meaningful engagement that we may have tonight. So I really do thank Claudia and Northwestern for having invited me this evening or afternoon in your case for this interaction. And I think I will stop there and have the session go into moderation.
Thank you, Dr. Makhema. That was just absolutely wonderful overview of really the Botswana response, which has really been a first in so many ways, especially in the continent of sub-Saharan Africa, and what tremendous progress in the program on a clinical level and research scientific capacity building. So it is open. We have lots of time for questions and discussion. I think there's one question in the Q&A right now, but other participants, please feel free to put them in while we're talking. Maybe we will start with this question from Ken, who asks, do you have a sort of standard messaging that your public accepts as credible? I think probably what's been successful in terms of the messaging with regards to the HIV pandemic. I hope I'm interpreting this question appropriately.
I think ultimately it is people taking responsibility for their lives. We have been previously in a where, top down, the government was the one that came up with programs and projects and whatever it was, and expected that people would just swallow them. But now the messaging has changed. You have to take responsibility for your own health. You have to test for you to know that you've got a particular disease, for that intervention to be undertaken as early as it possibly can. The demystifying the fact that, because disease very often in our environment people have presented late. And so we have focused on the earlier, the better. And secondly, involve the community leadership in basically propagating that message, whether they are political or traditional or religious, they have to be involved. We have very strong community advisory boards that assist in drawing the messaging scripts to ensure that these are much more easily absorbed and accepted by the general public. And then finally, I think the community healthcare workers, the cadres, and this doesn't take our professionals. Having a cadre of community healthcare workers who are taught on the basics in terms of disease causation interventions, early access to therapeutic services has certainly also helped. And a lot of sub-Saharan or Southern African countries, sub-Saharan countries have got these cadres of community healthcare workers, and they go into the community and people have trust in them. And therefore, increasingly one finds that we're using those for passing on these messages.
Sorry.
Right. I believe there's another.
Yeah, there is another question. So this is a remarkable work. Thank you. How generalizable are these results in other parts of the continent? So what roadblocks, how did you overcome? So I think that could apply to much of the research, but also some of the response that you had at a country level. Curious.
I think at the end of the day, one of the emphasis is for each country to get to know its epidemic, most importantly, because what may work in Botswana in terms of fighting the epidemic, the gaps which exist may be different from what may happen in South Africa, where the epidemic may be fueled by different socio-cultural practices that we may not have. South Africa, for example, some of the epidemic there is fueled by a cultural norm, especially in KwaZulu-Natal, where multiple concurrent partnerships in relation to men having multiple wives, etc. We know that that may be the case there. But we also do have multiple concurrent partnerships. As we said, from our perspective, doing the phylogenetics showed us that there are these clusters. They are small, but they're there. And it is within these small clusters that you get these transmission networks. Whereas in other countries, it may be the transmission networks are in larger clusters, and therefore, in terms of how you are going to intervene, is going to be certainly different. So I would say that it's really upon each country to get to know its epidemic, and that you know, what works in Botswana may not work in South Africa. But these community type projects and studies that were done, to a large extent, did tend to tease out the specifics within each particular context and environment where they were done. And that's how I would think I'd respond to that.
Great. So this is a question from Ramon Lorenzo. So really incredible work. 2 questions. Are you using full genome deep sequencing to study intra-host HIV dynamics, specifically for reservoir? Are you using phylogenomics to try to design intervention strategies?
Yes, definitely. I think genome deep sequencing is a technique that we are using for reservoir, and certainly for host HIV dynamics, and that I know I'm not a virologist, but definitely that's what we're using. Designing interventions, we have tried and are looking for specific interventions, and now, as I said, it's a question of whether we are going to be to get the funding that we need for phylogenomics, and being able to design specific interventions for where we have these high incident populations, because around the country, as I said, we can map out some of the hot areas. And so I think it is important that we are seen to do that, if at all we are to get the funding for that.
Great. So while we're waiting for, well, there's another question. So we'll answer this one first. So you mentioned including non-citizen populations at some point. Just out of curiosity, why is this important? Great question.
The non-citizens, unfortunately, you've got 2 kinds. You've got non-citizens who come legally in country, and therefore you can plan accordingly in terms of your procurements for them accessing public health services. And then there is a second kind of non-citizens who are illegal in country, and those tend to be far much more mobile, and you cannot track or trace them. Now, in terms of epidemics, I think the initial argument had been for those in particular, it would be challenging for you to want to start them on, say, enroll them in an antiretroviral program without knowing whether they are fixed stay in country for how long, whether they'd continue taking their therapy in country, or move on, default, come back, and end up with increasing the issues around drug resistance in country. And so these were some of the political decisions that needed to be made. I think the Sub-Saharan Africa eventually resorted to having the regional political bodies try and see how they could assist in ensuring that when somebody was started on therapy in Botswana, they should be able to continue to access that therapy in South Africa if they so choose to want to go to South Africa because they are illegal and they keep on moving. And that is something that is ongoing at the moment. And we hope that from the country's perspective in Botswana, as long as you give us an address, a physical address where we know that we can go and check you, you can enroll in our programs, even if you're a non-citizen.
Great. I think we have one question from Dr. Taiwo. I just asked him to put it in the chat, but he may be able to unmute himself. Dr. Taiwo, I'm not sure. Oh, it might be in the, here we go. So he is asking, what is the outlook for long-acting agents for treatment for PrEP in Botswana and presumably treatment as well? How important is it considered given the progress already recorded, and how will integration resistance and cost impact this decision? That's a great question.
Absolutely great question. We have incorporated long-acting agents in our treatment guidelines at this point in time, targeting specific populations, the adolescents, discordant couples, people who are involved in violent relationships, so it is currently just targeted. Part of that is because of people who have had breakthrough infections with poor adherence because of that. So it's currently planned in that manner. The cost, unfortunately, is still prohibitive. And that is the major deterrent. I think there are ongoing discussions with VIV and others, and I think they are now looking at patent sharing so that we can possibly have generics, but as to where that conversation is at the moment will determine whether we are now going to openly use the long-acting injectables as freely as you possibly can.
On that note, do you have any data on how successful your PrEP, your injectables have been in those sort of targeted situations? Just curious.
Yeah, I think at this point in time, one can only talk to the network data, like the 084 data, which is the real a substantive study that is ongoing at this point in time, and we're still gathering more data for those participants that have been enrolled in that particular study. But overall, at this point in time, one would say that the jury is still out there. What we know is that it's very widely accepted. Long-acting agents are widely accepted. It's just the cost at this point.
There is one other question. Any difficulties with getting informed consent? I'm going to sort of, it's a little open to interpretation, I'm guessing, with some of the research you've been doing, but I think it sort of brings up a wider question of participation in studies in general, and sort of and how that has really contributed, I think, to a lot of the success you've had with the rollout and just interventions thereafter.
In terms of informed consent, largely, we have a country where people are still, whether it's altruistic or there's genuine intent to really want to do good, they are participating in these studies. So I think we haven't really had major informed consent issues at this point in time. And to the extent that most of the research has been done in institutions such as ours, or we are the leading one, where there is a higher perceived care system compared to the public healthcare system, people will just volunteer for participation, and our enrollments and our retentions in these clinical trials speak for themselves. And so one at this point in time doesn't see a lot of research participation fatigue by participants enrolled in our studies. What is challenging is really the criteria and eligibility for them to enter in the studies. That is much more difficult at this point in time. You know, fulfilling the eligibility criteria, but not the actual informed consent itself.
Mm-hmm. Makes sense. So while we wait for other questions, so I have a question on, you know, you didn't talk about this, but obviously it's exhaustive topic. But curious as to, you know, obviously we have we're facing an aging population of HIV. Every continent is, specifically in sub-Saharan Africa. How are you as programs sort of dealing or managing comorbidities, the aging process, the sort of future of really not really having to worry too much about HIV so much, as long as there are therapies available, but now the emerging comorbidities, and how does sort of integrated care fit into that, if that's something that you're doing?
Thank you. Great question. I have no doubt. I think as a country that was the first to start antiretroviral therapy in the subcontinent, a lot of the data for comorbidities amongst the aging population will be generated from our program. We are we do have studies that are ongoing on the comorbidities, on malignancies in persons with living with HIV, and as part of our expansion of our research, we do have now, like Professor Mosepele has got an interest in cardiovascular morbidity amongst persons with living with HIV, and the intercare study that he's doing is following up exactly that particular cohort, looking at incidents, malignancies, hypertension, diabetes, etc. And I think you know, everybody has been talking about antiretroviral therapies, you know, having to be incorporated or somehow interfere with the genome, and whether that shall lead eventually to increase in malignancies. And we are seeing to a certain extent an increase in malignancies, but we'll have to wait for some of those data, such as the intercare study done by Professor Mosepele.
Great. And one last question I have, sort of pivoting a little bit to the training programs. I'm curious, you know, being involved, as you know, with these myself, and our joint work on the HBNU, curious as to sort of how well you're able to maintain your trainees who have been through some of these postgraduate degree programs or postdocs in academic positions in Botswana. Sort of what's the funding landscape like for them to sort of being able to continue their research? Are you losing them to other global health entities, so to speak?
Absolutely. You know, that's a brilliant question. I think people get to know where the successful programs are. And I think funding postgraduate, postdoctorate fellowships and retaining them is increasingly challenging. And then within the institution, we've got limited infrastructure. So we have retained them in strategic areas and try and seek funding in strategic areas in those disciplines where we did not have capacity, like in hepatitis, in TB, HIV cure. You obviously cannot do everything. And where otherwise we would not have a position or the infrastructure, we work on collaborations. I like working with institutions, say at Stellenbosch or at KwaZulu-Natal, where you co-share a person's FTE or research 50% or whichever way it may go. But that's how we are working, and with local institutions such as the University of Botswana and the University of International University of Science and Technology, on how we can co-share the expertise with them, assisting with some of the funding for the person's postdoctoral work. But it is challenging.
Thanks, really insightful. So we are 1 minute from the hour, and what a great conversation, and some really really great questions, and great participation. So, and it's just been so great to hear again from your program and Botswana in general, and its tremendous success in getting this far with the HIV pandemic, and really a model country. So so exciting to hear about it. Lessons learned for sure. Once again, thank you so much for your time. We appreciate it's pretty late there, so very much appreciated. And thanks again to all the participants for joining. Just to conclude, we invite you to join us at our next IGH seminar, which will be taking place on the April the 3rd, with Paddy Gravett, who is the Deputy Director of the National Cancer Institute Centre for Global Health. This event will be held in person, so more details to come on that. Again, thanks for everyone for joining today. A recording of this webinar will be available online and will be shared via our newsletter. Thanks once again.
Oh, brilliant. Well, thank you for having me, and good night.
Good night.